Hi, this is Jocelyn Compton. Let's cover the respiratory physiology section. Hopefully you'll find it inspirational. Okay, moving on. Lung volumes are super high yield. They're guaranteed to show up on your exam, so you should know them backwards and forwards. Plus, lung volumes will come up frequently throughout the rest of your med school education and your medical career in almost every field. First, let's define some terms. What are the important parameters? Let's go through the terms by using this graph. Lung volumes are these four individual measurements. Here, you can see the fluctuating lung volume over time. Let's go through it step by step. These are normal breaths. This is a deep inspiration, a deep breath, and then a deep exhalation, and then back to normal breathing. The inspiratory reserve volume is the amount of air that can be inhaled after a normal inspiration, the deep breath. The tidal volume is the amount of air that moves into the lung with each normal respiration. This is an important parameter when establishing the efficiency and therapeutic nature of mechanical ventilation. The expiratory reserve volume is air that can still be breathed out after normal expiration. That's when you force out as much air as possible. I like to think of this as the low tide mark, where the water on the beach is the air in the lungs. It's as low as it's going to get naturally, but then there's still some water left in the bay. Like there is still air left in your lungs after you force everything out. So what do we call the leftover air in the lungs after maximal expiration? The residual volume. Alright, check out this mnemonic. Liter. L is for lung volume, I is for inspiratory reserve volume, T is for tidal volume, E is for expiratory reserve volume, and R is for residual volume. So what factors affect lung volumes? Lung volumes tend to be greater in tall people, smokers, and people who live at high altitudes. It's also important to understand how the different lung volumes are related to each other and how each can be determined. A capacity is made up of multiple volumes. The inspiratory capacity is the tidal volume plus the inspiratory reserve volume. The functional reserve capacity is the volume in the lungs after normal expiration. So if that's the case, which volumes comprise the functional reserve capacity? That would be the expiratory reserve volume and the residual volume. On the next page, we'll talk about the functional reserve capacity as where we find the inward pull of the lung balancing the outward push of the chest. We'll get there in a minute. The vital capacity is the tidal volume plus the inspiratory reserve volume plus the expiratory reserve volume. Basically, everything except the residual volume. So it represents the amount of air you would breathe in if you first exhaled as much as possible and then inhaled as much as possible. Okay, finally, how do we determine total lung capacity? Well, it's basically the sum of all of these volumes. Throughout this talk, I'll be referring to each of these terms by their initials. For example, inspiratory reserve volume will become IRV. You should be comfortable enough with these terms to be able to use the initials interchangeably with the terms. Lung volumes are important in the diagnosis and management of many lung disorders, and likely to appear on step 1. For example, you see a 55-year-old coal miner with a long-standing cough and progressive shortness of breath. He has inspiratory crackles, and you see patchy bibasilar interstitial infiltrates on chest x-ray. So what would you expect the lung volumes to be like on pulmonary function testing? Well, this is likely a case of anthracosis, or coal miner's lung. As we'll discuss in more detail soon, this is a pneumoconiosis and a restrictive lung disease, and it is typically characterized by decreased lung volumes, including FVC and TLC. In obstructive lung disease like COPD, you see increased RV at the expense of less FVC because of air trapping. Recall from our respiratory anatomy talk that dead space does not participate in gas exchange. So, what's physiologic dead space? Well, it's anatomical dead space from the conducting airways that we talked about in the respiratory anatomy section plus functional dead space. So what is functional dead space? That's where you have alveolar ventilation but no perfusion. The apex of the lung is an example of functional dead space, where air is inspired and filling the alveoli, but no blood is flowing through the capillaries to participate in gas exchange. And why does this happen? Because of gravity. Recall from our respiratory anatomy talk that dead space does not participate in gas exchange. So what's physiologic dead space? Well, it's anatomical dead space from the conducting airways plus functional dead space. So, what is functional dead space? That's where you have alveolar ventilation, but no perfusion. So therefore, there's no gas exchange. The apex of the lung is an example of functional dead space, where air is inspired, it fills the alveoli, but no blood is going through the capillaries to participate in gas exchange. Why does this happen? Because of gravity. Anatomic dead space tends to be fixed, but functional dead space can significantly increase in conditions like COPD, where you get a classic ventilation-perfusion mismatch, or it can decrease, such as during normal exercise, when the upper lobes are more heavily perfused for maximal gas exchange. Physiologic dead space can be estimated by using the Bohr equation, where VT is tidal volume, PaCO2 is the arterial CO2 content, and PeCO2 is the content of CO2 in expired air. This makes logical sense because only ventilation involving gas exchange produces CO2. The closer PeCO2 is to PaCO2, the less physiologic dead space ventilation you have. As this difference decreases, more of the CO2 in the pulmonary arteries is being expired with each breath. You can keep this equation straight with the mnemonic taco, peco, peco, paco. Ventilation is the movement of air into and out of the lungs. It has a specific mathematical definition, defined in two different ways: the minute ventilation and the alveolar ventilation. The minute ventilation is the total volume of gas entering the lungs per minute, and is defined as VE equals tidal volume times respiratory rate. However, this is different than the volume of gas that reaches the alveoli. Why? Because of dead space, mostly. Can you think of a pathology that would decrease alveolar ventilation? That's right, any obstruction that would limit aeration of the alveoli, like cystic fibrosis with mucus plugging. Alveolar ventilation is described as VA equals the difference between tidal volume and dead space times the respiratory rate. Let's have a flash quiz. What letter is the functional reserve capacity? The answer is F, the volume in the lungs after normal expiration. Let's talk now about the mechanics of the lung and chest wall, and how this works in pulmonary physiology. The story here is lung compliance, which we'll talk about in a bit. Here you have a schematic representation of the balance of static elastic recoil forces in the respiratory system. The static volume pressure curves of the chest wall, lungs, and respiratory system are shown. Take note that the distending pressure, or the pressure you need to add to expand or shrink the respiratory system, is simply the sum of the distending pressures of the chest wall and the lungs. When you're breathing, there is a tendency for the lungs to collapse inwards and the chest wall to spring outwards. When the lungs are at their functional reserve capacity, the inward pull of the lung is equal and opposite to the outward push of the chest wall. Here, the system pressure is the same as atmospheric pressure, and there is no net air movement. At this point, the airway and alveolar pressure are both zero, and intrapleural pressure is negative. By the way, why is intrapleural pressure negative? Negative intrapleural pressure helps keep the airway open. Please note that this is where the distending pressure of the chest wall is zero. This is called the resting volume of the wall, and it's about 50% of the vital capacity. This directly ties in with the concept of compliance that we mentioned earlier. Compliance is defined as the change in volume for a given pressure. So higher compliance means that the same pressure change will create a larger volume change. What's the inverse of compliance? That would be stiffness. The slope here is a measure of compliance. So you tend to have more stiffness or less compliance at the extreme volumes, and therefore you see a flatter curve, like here and down here. So if you have a patient in your ICU who requires ventilator support for adult respiratory distress syndrome, or ARDS, will you typically need higher or lower positive airway pressures to ventilate their lungs? Well, in ARDS, you have pulmonary edema, which makes their lungs stiff and non-compliant. You're going to need more positive airway pressure to get the same tidal volume, so you'll see a flatter volume pressure curve. Ultimately, you'll need higher pressures to ventilate their lungs. Hemoglobin is super important to know for the boards because of how it carries oxygen and the normal physiologic and pathologic stuff that can happen to it in terms of hemoglobinopathies and thalassemias. Check out this hemoglobin molecule. Adult hemoglobin is a polypeptide comprised of 2 alpha and 2 beta subunits. Do you remember the other kind of hemoglobin that occurs during development? Yeah, fetal hemoglobin. Each subunit has a non-protein heme group containing a single iron atom that forms a strong covalent bond to a histidine residue in the globin chain. There is a taut form, or T form, which has a low affinity for the oxygen on the heme molecule, and then the relaxed form, or the R form, with almost 300 times greater affinity for oxygen. Does carbon dioxide bind to heme? No, it binds to other parts of the hemoglobin protein to form carbaminohemoglobin. Carbon monoxide, on the other hand, does competitively bind at the same heme site to form carboxyhemoglobin, which we'll discuss shortly. Another important concept to understand is the positive cooperation that hemoglobin demonstrates. So what's positive cooperativity? The binding of the first oxygen molecule pushes the hemoglobin into the R, or relaxed state, by tugging on that histidine residue. So it becomes easier for the oxygen to bind the other 3 heme groups. So the only time hemoglobin is in the taut state is when there's no oxygen bound, and it's relaxed when 1 to 4 oxygen molecules are bound. This explains the sigmoidal curve to the oxygen hemoglobin dissociation curve, which I'll show you in just a bit. Negative allostery occurs when something like 2,3-BPG binds to hemoglobin, stabilizes the T or taut form, and reduces its overall affinity for oxygen. Do you recall when humans physiologically produce 2,3-BPG? At high altitudes. Why does this make sense? Because in conditions of low oxygen tension, like at altitude, the hemoglobin must release oxygen more readily in the tissues. But what about binding oxygen in the lungs? Well, actually, there's enough oxygen in the lungs, even at high altitudes, for oxygen to bind fully to the hemoglobin molecules. So 2,3-BPG helps to dissociate the oxygen in the tissues, where it really needs to be used. Now, let's have a quick word about fetal hemoglobin. Here's the normal adult hemoglobin saturation curve, which is sigmoidal because of positive cooperativity. After the first oxygen binds, the hemoglobin becomes relaxed, so the next 3 bind really quickly, which you see as the rapid rise in the curve as oxygen saturation shoots up. Fetal hemoglobin is comprised of what? 2 alpha and 2 gamma subunits, rather than 2 beta subunits, and has a higher affinity for oxygen than adult hemoglobin. Here you can see the difference in oxygen saturation curves, with the fetal hemoglobin curve being left shifted. This makes sense, right? Because the fetal blood has to acquire oxygen from maternal blood, so it has to bind with greater affinity. One last point is that fetal hemoglobin pretty much dominates from week 10 until birth, when it rapidly tapers off over the first 6 months of life. Let's have a flash quiz. The lungs tend to blank, collapse inward or expand outward, and the chest wall tends to blank, collapse inward or expand outward. The lungs tend to collapse inward, and the chest wall tends to expand outward. Good job! Let's talk about a couple of highly testable conditions that can modify the effectiveness of hemoglobin, leading to tissue hypoxia from decreased oxygen saturation and content. Methemoglobin is the oxidized form of hemoglobin, containing the ferric Fe3+ iron rather than the ferrous Fe2+ iron. This form of hemoglobin is less effective at binding oxygen, and the patient gets a functional anemia. They can also become cyanotic. Interestingly, methemoglobin has a high affinity for the cyanide ion, which has an important therapeutic implication that we'll come back to. So how can you get methemoglobinemia? So most commonly, you get it secondary to oxidizing medication, such as nitrites, dapsone, and benzocaine. When should you be alerted on step 1 to a patient who might be taking dapsone? Someone on multi-drug therapy for leprosy. Methemoglobinemia can also be an inherited disorder, and the most common inherited form is an autosomal recessive disorder where you have a deficiency of cytochrome B5 reductase, which converts methemoglobin to hemoglobin. So how do you make the diagnosis? The classic presentation here is clinical cyanosis with an O2 sat on routine pulse oximetry of 85 to 90%. But then, when you get a blood gas, the arterial PO2 is normal, and the blood is chocolate brown, and it doesn't turn red with oxygen exposure. Acquired methemoglobinemia can be treated with methylene blue, and by stopping the offending drug. On the other hand, hereditary methemoglobinemia typically doesn't require treatment. As I mentioned, methemoglobin preferentially binds cyanide over oxygen. So, because of this, methemoglobinemia is actually useful in the treatment of cyanide poisoning. So how does that work? Well, you give the patient nitrates to convert hemoglobin to methemoglobin in order to bind the cyanide and remove the cyanide from circulation. Thiosulfate is then used to bind this complex methemoglobin cyanide molecule, forming thiocyanate, which is then excreted through the kidneys. Carboxyhemoglobin is typically caused by carbon monoxide poisoning, where hemoglobin binds to carbon monoxide rather than to oxygen. In fact, carbon monoxide has almost 200 times greater affinity for hemoglobin than does oxygen. Carbon monoxide binding means there is less hemoglobin available for oxygen transport. On top of this, there is a left shift in the oxygen-hemoglobin dissociation curve, which means less oxygen offloading in the tissues. So, how can we tell the difference between someone with methemoglobinemia and carbon monoxide poisoning? Methemoglobin makes the patient cyanotic, while carboxyhemoglobin makes the blood bright red. Thus you hear the mnemonic, when you're cherry red, you're dead. The other board pearl to remember is that pulse oximeter may say 100% O2 saturation because it can't tell the difference between carboxyhemoglobin and oxyhemoglobin. Methemoglobin, on the other hand, will have a pulse oximetry reading of 85 to 90%. Finally, how do you treat carbon monoxide poisoning? Because you certainly don't want a dead cherry red patient. Well, you'll want to get the patient away from the source of carbon monoxide. Then you're going to want to treat with 100% oxygen as soon as possible. Let's have a flash quiz. What color will the blood appear in methemoglobinemia? The answer is chocolate brown.